We are live. So, hello everyone. Thank you for joining us today. I have Sara and Hannah here to talk about the cool stuff that Waymark is doing. And before we jump into the study that they published and going deeper into those impressive results, maybe while we wait for some more people to trickle in, Hannah, first question to you before introducing yourself. Like, what's the book or one of the books that you recommend most to other people that you really enjoy, fiction or non-fiction, doesn't matter.
Great question. I think my favorite nonfiction, I'm a big nonfiction reader, is East of Eden, which is an old school John Steinbeck novel. And then I was just trying to think, Rick, like nonfiction wise, the thing that I've reread recently, we did a book club on it at Waymark in like early days, was a book around automating inequality, which I think is just really something important for us to all keep in mind as we lean more and more on machine learning and like learning from what not to do from all of the examples that have been done. I think it's a good reread for folks who haven't read it in a while or who are new to the topic.
Very timely, so I will add that to my list as well. What about you, Sara? Any books that you like to recommend to people?
So as Hannah knows, I just read East of Eden for the first time because during a team icebreaker, I asked my leaders for their favorite books, and Hannah and Marguerite, another co-author of the NEJM study, will talk about both of their favorite books were East of Eden. So highly recommend. Currently rereading A Little Life, which is another favorite fiction book. Nonfiction, I'll have to go with Innovator's Prescription, Clayton Christensen, like obviously classic in this space that we all work in, but I reread it pretty regularly.
It's indeed a very good one as well. And I never read East of Eden either, so I will also add that to the list too. And then we can do a book club about it as well at one point. Cool. So maybe what would be helpful is like, can each of you like briefly introduce yourself and the role and like how it like what you do within Waymark, so people have a sense of who you are and what you do. So maybe Hannah, you can kick things off again.
Yeah, sure. So thanks again for the invitation to join you, Rick. My name is Hannah Ratcliffe, and I am our Vice President of Care Model and Quality at Waymark. And so my team, the Care Model and Quality team, works to kind of define what our core care model is, support our operations and care teams to implement that care model, monitor our performance, and iterate as needed. We're also kind of a centralized hub for ops, so policies and procedures, working with legal and compliance, supporting new implementations. And we also work really closely hand in hand with our product data science analytics teams to make sure that there's really tight alignment between our care model and our products.
Cool, helpful. What about you, Sara?
So I lead operations at Waymark, which kind of consists of a few functions. Hannah's got her care model and quality team, defining the care model, building infrastructure to support its implementation. I also lead our market operations teams, which are executing the care model through our patient-facing care delivery teams across our markets, and an implementation team that is responsible for bringing our care model to new markets and partners. So would say like care ops as we use it in this community sits with Hannah. That is Hannah's function, and also have the privilege of leading teams that are bringing that to life in our markets.
Yeah, cool. And then can one of you like explain what Waymark is, like what's your care model and like why we are here today? Like maybe briefly talk about the paper that was published as well, so people have like a sense of what you do as well.
I'll go for it and try to synthesize, Hannah, and anything that I miss. Waymark is a public benefit company focused on improving access and quality of care for Medicaid participants, exclusively in partnership with health plans and providers. And I describe our care model as having three core elements. Number one, people, so community-based care teams that consist of community health workers, care coordinators, clinical pharmacists, pharmacy technicians, therapists, who build trusted relationships with patients. Second piece is evidence-based care pathways that guide the clinical and social interventions that we deliver to patients based on their needs and goals. And then third element is technology. So have algorithms to identify and prioritize the rising risk patients that we work with, and have a patient relationship management tool that makes it super easy for our teams to deliver care. So bringing community-based care teams plus evidence-based care pathways plus technology together to deliver the Waymark experience. And last month, a peer review study on our year one results, so our 2023 results, was published in the New England Journal of Medicine's Catalyst publication by Hannah and several other brilliant colleagues that kind of demonstrated the benefits of this care model. So we saw that for the patients that received Waymark interventions, we saw a 23% reduction in all-cause ED and hospital visits, and a much more significant reduction in avoidable hospitalizations compared to a matched control group. Had completed over 60% of patient-identified goals, with many others actively in progress. Saw a pretty significant reduction in administrative work required by our teams to support patient outreach and engagement. And so just like philosophically at Waymark, like we believe in just sharing the details of what we do to inform efforts by others to kind of collaborate and innovate to improve the experience for Medicaid participants. And so we're excited to publish on our work, kind of a lot of detail about things we tried, things that worked, didn't work, and are excited that you wanted to chat with us about that today.
Yep. Yeah. Thank you for obviously open sourcing many of the pain points and the lessons that you went through. I also want to emphasize that the study in itself, I read it 3 times. It's like a must read for everyone building in the ecosystem. And so the goal of today is for the audience is not to just like talk about what was already written, but it's like to go like maybe a few turtles deeper into what was written and like deeply understand what was done. And so for some context, so the paper, the use case, the case study is like written in multiple phases. Like the first phase, if I can call it like that one, was alignment. And so maybe Hannah, you can explain that phase better than me, but the short version is like before creating and actually seeing patients, you made sure that what you design is aligned with the problems that the payers are having, the health plans of patients and the primary care providers have. And so as part of that alignment, you talk about it quite deeply in the paper. So you talk about like, hey, we worked with diverse stakeholders, so the patients, health plans, the primary care providers, to define the pain points. But then can you maybe explain to us like what was that conversation look like? Like how did you ensure that each group felt comfortable sharing the challenges? What adjustment did you make across these groups to get more insights? Like what was that in practice, that alignment phase?
Yeah, absolutely. So I think, you know, maybe not as explicit in the paper, but want to just mention before we get into, before we even started going to stakeholders, is that we, you know, really tried to do our homework by starting with the literature and understanding what's worked and what hasn't in this space. And there's actually lots of evidence, as I'm sure everyone knows, around the problem, you know, the importance of social determinants of health, the particular challenges around Medicaid care delivery, both the promise and the challenges that primary care in general is facing throughout the United States. And so there's lots of evidence about what the problems are, and there's also actually a good amount of evidence about what works. And so we tried to really, you know, start by synthesizing all of that together, firmly rooting our kind of draft care model in this evidence, and really had the goal of building off of what was out there, what had been shown to work in smaller cases, and scale that to the Medicaid population, you know, at scale. And so we started by just using that evidence base to kind of identify the basic scaffolding of our care model and the like core tenets of care delivery that we really wanted reflected in that model. And then we went to our advisor. So, you know, we talk about kind of advisory board and patients. I think what we actually did was smaller scale, and I think that enabled just like more free conversation and information sharing. And so we were often approaching people we had a relationship with who were established in their field, who there was a little bit of trust there with someone in the like small but mighty initial Waymark team, to really encourage their honest feedback. And we were able to kind of dig in individually with advisors, with patients, with other providers around a huge range of issues that informed how we kind of set up our model and tested some of the assumptions that we had to date. We also did a lot of shadowing in our early days. So before we had a care model, even on paper, we did a bunch of shadowing of providers and their teams to really see firsthand what all of the pain points were that maybe are so kind of ingrained in people's day-to-day practice that they don't bring up when they're asked about their challenges. It's just such a basic fact of life. So that was a huge piece for us. And then we also did a lot of shadowing of our community health workers and care coordinators and patients who were receiving kind of the first draft of our care model before we officially launched. And so I think, looking back, I think one of the really critical components to those conversations and those shadowing efforts, again, was like trying to build that trust and showing up with just a huge dose of humility and establishing right off the bat, that we've done our homework. We're not going to ask people to tell us information that's well known and out there and we should be able to figure out for ourselves. And then also B, that like the person that we're talking to is the expert in whatever we're asking them about, and that the only right answer thing that we're looking for is what their experience has taught them. And I think that bringing that humility, being willing to kind of admit where you don't know what you're, where you don't have an answer, or you don't have an opinion, or you're struggling with this tension that you're seeing, I think really kind of sets up whoever you're talking to, whether it's the CMO of an MCO or a patient who's receiving our pilot services, to be open and share their real feedback with us.
And was the approach like very like PhD like you had a conversation, then you transcribed it, then you used like qualitative assessment to code it into like a code tree, like all of that? Or was it more like you create a summary, you put it on like an Airtable or a spreadsheet, and then you define based on that? Like what did that look like?
Yeah, that's a good question. I would say it was a little bit of both, and often just kind of somewhere in between. So when I arrived at Waymark, I came from more of a research background. I was like, okay, where's my qualitative software here? And we weren't using that per se, but we were trying to be rigorous and methodical about how we, were extracting themes, holding these back up against our kind of assumptions and our care model, and looking for, where there were points of diversion, points that were reinforcing what we were already trying to do, and kind of synthesizing as we go.
And so the advice that you would give to like anyone in the room that is like starting from scratch is like you use the evidence that we already have available, like the internet, the papers. You build some hypothesis, like an hypothesis around like this is a problem, this is a problem, this is a problem. Then you talk to end users like patients, health plans, like your customers, let's say. Then you validate, and then based on that, you have like a list of problems to solve. Would that be like an accurate summary, or do you think I'm off somewhere?
No, I think that's a great summary. And I would just say, I think the other piece that I would add is that it's not one-off. We did this before we launched, but we're still doing it. We still have advisors that we go to, and we dig into questions, and we kind of bring our big hairy problems to them and get their input. We're also, still doing a lot of shadowing of our care teams and their patient interactions to understand what's working. So I don't think this is like ever a one and done type of activity.
Yep. And so one of the fears that many people have is like the more feedback that they ask, the more things that they need to fix. Like product is the same, like you ask feedback from nurses and you ask what do you want to see differently, and I'm a nurse and I will say I want this and this. So how did you consolidate and then like prioritize the feedback? Like, okay, for our V1 of our care model, Sara, we need to build this and this, but we will ignore those, for example, pain points for now. Was it like a process, or was it just like, bit of chaos?
I'll never say it wasn't a little bit of chaos, but I think any new venture is. But no, there was definitely a process. Again, there's tons of information out there. We got a lot of great really rich feedback from our advisors and from patients and from these shadowing experiences. And we did a ton of synthesis. But I think what we really tried to do was go back to those like core principles that we put down on paper as our starting point and say, you know, it's not that the specifics don't matter, they absolutely do. But what we found as we started to dig in was that a lot of like the disagreements maybe, or the points of tension, were really more surface level. And what we were hearing consistently works from the evidence, from our advisors, kind of came back to some core underlying principles. And there's different ways that you can, you know, execute on those. But I think keeping that North Star of like, here's the principles of what we're trying to do, the tenets of what we're trying to do, helped us not feel so overwhelmed, and instead see opportunities to test different things out when we would see those points of tension. So, you know, I think an example of this is like different programs and different advisors that we read about, talked to, use like different tools and workflows for patient onboarding and goal setting. It all looks a little bit different, but at their core, all of those successful examples do a couple of things. You know, they're working to build patient trust right off the bat. They're often using conversations rather than like a screening tool that patients have filled out 5 million times in different settings. And they're anchoring on like a couple of things that matter most to the patient and going from there. And like once you can boil down to those core elements, we can then kind of pick and choose and say, let's test out this tool, or what if we did A, B, or B, A, and you know, that different order, and see what worked best. But it kind of gave us, I would say, a framework for making sense of the complexity rather than getting lost in it.
Yeah, that makes a lot of sense. And then obviously once you defined, let's say, the V1 of your care model, what you then need to do, and that was also the second phase in the paper, was training and development. And so obviously training is easy when you only need to train like a physician or like one type of role, but you made yourself like, you made it more difficult because you had like a diverse team of like, you had community health workers, care coordinators, social workers, pharmacists, therapists, and probably many more roles. And so each role has like unique skills, has different requirements, like different roles within a workflow. So can you walk us through like how you structure this multidisciplinary training? Like what went into that? Because it feels like a pretty damn hard job.
Yeah, I'm happy to jump in. And so this was kind of the moment that I joined Waymark. So Hannah was at Waymark before me. Hannah led sort of the early research efforts in collaboration with a few other colleagues. And when I joined, we were in the process of kind of synthesizing and finalizing V1 of training. And candidly, like the initial focus for us was on community health worker training, specifically because CHWs are the majority of our workforce. And so invested a ton in V1 of community health worker training, brought together a mix of expertise internally, like our national CHW lead has her doctorate in community health education, research focus on community health workers, familiarity with the state certification requirements and the markets we were launching in. Hannah and her team, sort of care model experts who are intimately familiar with like the evidence base and proven models. Also multiple L&D experts, like familiar with how do you deliver content effectively through different mediums. So like strong, like multi-month internal collaboration. And then we tested that with lots of the advisors, external subject matter experts that Hannah mentioned, and also with our earliest CHW team members that we brought on a few months prior to starting to scale up hiring. And so like huge focus there. For our other multidisciplinary roles that you mentioned, our first hire in each of those disciplines were local leads in our markets. So we hired, you know, our first local clinical pharmacist lead in Virginia, our first local therapist lead in Washington. And those initial local leads partnered really closely with Hannah's team to basically, we took many of the core elements of the CHW training that applied more broadly on topics like motivational interviewing, trauma-informed care, harm reduction, and sort of combined some core content with role-specific training on care pathways and workflows that our local leads really helped guide the development of. And so, really for our first over a year, we had separate training experiences across these different disciplines within our model. And I'd say like one lesson learned was the benefit of a common foundation for the entire multidisciplinary team, more so than just sort of pulling some of the same content from training to training. And so we evolved toward an approach where we have an all care delivery training for the first 2 days. That's really this shared grounding that all of our multidisciplinary care team members go through together. Feels much more effective. I'd say another thing early on, these first 3 to 6 months, we're very focused on what I'll call classroom training. So like, what is that upfront sort of few weeks of education before you go out and sort of try to put it into practice? Definitely saw like a need for more robust structure around the on-the-job training that follows classroom training. And obviously that was enabled by growth and scale. Once you have folks on the ground in communities actually doing the work, there's opportunity for others to shadow, to reverse shadow. And so like in our second year this year, have put much more structure around on-the-job training and like task lists for shadowing and just kind of making sure that is more comprehensive and consistent across communities than it was early on, where we really just emphasized that common classroom training module.
And have you tried to scale training? What I mean by that, like, so is it, for example, still like in-person training, or have you like recorded everything and is it now like just watching videos, or like what's your philosophy there?
Yeah, that's a great question. When we launched our first markets in early 2023, it was predominantly in person and wasn't scalable and sustainable the way it was done for those first 2 markets. And so we have iterated and figured out over time what's the right kind of combination. I'd say at this point, it's probably 50-50. Some like virtual elements. We also see a ton of benefit from onboarding like classes of CHWs across markets together. So if we have 3 new CHWs starting in the same class, 2 in Virginia and 1 in Washington, having a shared experience with some of the like early virtual online training. And it's still very interactive, the virtual elements, but typically by the end of the second week, there always is an in-person element. Some of it is like skill validation on what folks learned in classroom training. And then, like I said, really emphasize shadowing, reverse shadowing as we're gearing up to launch some new partnerships and markets. We're thinking about, okay, as we launch like a next new market, what does that look like? I think we feel strongly that certain aspects of the training really need to be done in person to be effective.
Yep, that's helpful. And then so once you have done the training, I think the third phase was like deployment and integration, like deploying your team in each community and then integrating with the PCPs that you work with. And so in the paper, you talk about like you want to create a tailored approach based on each provider preferences. So based on their workflow preferences even. And so I love that concept, but obviously from an operational perspective, it sounds like a nightmare, especially if you scale. So how did you like operationalize these individual nuances without overwhelming the care team, because they still need to remember those nuances? Or like what's the plan of making this more scalable as well?
Yeah, I'm happy to start this one and definitely chime in, Hannah. And this is the bread and butter of our implementation team. And maybe for a little context for the group, we partner with health plans to sort of take on populations to manage, and then partner with their PCPs to wrap around those PCPs and really expand the capacity of those PCPs, help engage hard-to-reach patients. And so we've got a health plan partnership in place. We're now engaging with sort of a group of PCPs. Maybe there's 4 or 5 PCPs that we're starting with. And like you said, onboarding those PCPs and figuring out how are we going to work together. And I'd say early on, we again kind of had a V1 provider onboarding process where we meet with a point of contact at a provider partner and like talk through areas of collaboration. Big ones were things like appointment scheduling. How are we going to schedule appointments with them? How are we going to coordinate care for shared patients? Like program referrals, how will they refer to us? How will we refer to them if they have certain in-house resources they want us to help engage patients around? How will we raise awareness with individual providers? And in our initial handful of relationships, we basically worked through that ad hoc with our like operational points of contact with each of our provider partners to like better understand needs and preferences, both of like individual providers, but also different types of provider partners. So I think one thing that's different from like some organizations that partner with providers is we partner with lots of different types of providers. We're partnered with big health systems. We're partnered with FQHCs. We're partnered with, you know, smaller medical groups. And so the first handful of provider implementations, it started out a little chaotic, sort of working through preferences. And then like, I'd say after the first maybe 3 or 4 started to like take what we heard and kind of standardize a few options for collaboration in each of those areas so that like it wasn't a total free-for-all, but also wasn't like one size fits all and recognized different needs of different partners. And so like, for example, with like referrals, how are providers going to refer patients to Waymark who they think would benefit from our support? Like you have 3 options. You can send a referral through your EHR, you can use a certain referral form, or you can contact your care coordinator directly. Which of those 3 options do you want to be the option for your practice? So we kind of moved from a little chaotic to like the slide with 2 or 3 options for each of the decision points. But there is still like variability. And I'd say like this isn't 100% the case, but like probably 90% plus try to limit areas of customization across provider partnerships to really only impact our care coordinators. And so like our care coordinator role is our primary point of contact between our care team and practices that we work with. And so most of those areas of customization around scheduling or communications, a care coordinator has a couple of providers that they're focused on that they're sort of adhering to those preferences. But for CHWs or therapists, they don't need to think about differences across patients of different types of providers. So we try to do that to the greatest extent possible. And then, yeah, I'd say maybe one other learning is like we use a structured approach at this point. Like we use a questionnaire to kind of lay out alternative options and like understand provider preferences in quite a structured way to try to control that to the greatest extent possible. And we'll usually do that prior to our implementation kickoff with a provider. So like we get as much information as we can, and then we can kind of go into a conversation saying, these are the options, this is what we heard, let's talk about how to make this happen.
And so for people that want to do the same, I think that your approach makes sense where you first like offer your partners a free-for-all because it allows you to understand deeply like what their preferences are, and then based on those learnings, then you can get into like creating that menu, which I really like. And so one thing that I also found interesting, like not like it fell under hurdles, but I think it's related to deployment as well, is like you've built some pretty cool tech that was like able to reduce admin time, for example, by 34%. And so maybe a question to you, Hannah. So I assume that you created like a custom patient relationship management tool to support your complex care models, since an EHR in most cases cannot handle this complexity. So one, is that the correct assumption? And then two, like, were there like some like core features that you think were like absolutely needed before it was lovable by your the care team that we just talked about?
Yeah, it's a great question. We actually started out not wanting to build our own tool. And we ultimately did. So we spent a lot of time in kind of early days looking at lots of different EHRs, lots of different off-the-shelf CRMs, and basically found that none of them were really centered around the community health worker experience, which again is kind of the core of our model. And that meant that they often had like way too much of the wrong kind of information and way too little of the type of information that we really needed for our multidisciplinary teams and for community health workers in particular. And so as we set out to kind of build our product, I would say, we were really focused at first, our MVP, on just like a few core features. We needed a patient list that care team members could use to kind of sort and see who was assigned to them, who was assigned on their panel, and who else was working with that patient. So really focused on that coordination piece within our care team. We needed a patient profile that care team members could use to kind of see a full history of all the things that we had done with or for this patient. And again, like really focused on that continuity and coordination piece within our care teams. And then I think within that profile, the piece that for us is one of the most important and why we ultimately decided to build our own tool was centering that profile, our build, our use cases on patient goals. And so patient goals take up like the vast majority of the real estate in our tool. And we're really anchoring kind of our activities, our updates, all of that around those goals. And rather than diagnosis codes or billing or anything like that. And so that really helps, our care team members stay focused on what's most important for our patients from their perspective. And, I think over time, we're certainly working to continue to make our product more lovable by our care team members. But I think the priorities, those core features are still there, of course. And I think the priorities to continue to make it more lovable really consistently focus around maximizing like the utility and the efficiency of our product for population health and care at scale. And then also working to incorporate more and more automation of our workflows into our product so that we're surfacing, the right information, the right tasks, the right time for different roles, and not having to have folks kind of move back and forth between different applications. Oh, Rick, you're muted.
You're on mute, Rick.
Sorry. So the automation is interesting. That also touches upon like the book that you mentioned earlier. Do you have like a certain framework of like things that you would be comfortable automating and things that you would not feel comfortable automating? Because that's always the struggle, is like care coordination engagements, like scheduling an appointment sounds something that you want to automate, but it can also mean that in that conversation, the patient mentions something that then helps you prevent an admission, for example. So how are you like thinking philosophically, like from a product or like ops perspective about that question?
Yeah, that's a great question. I think, and Sarah, I'd love you to chime in here too. I think a couple of things that we're thinking about as we automate within our tool are making sure that it's really clear where information is coming from. So if we're asking our care team members to act on something that's automated, we're telling them, this is a suggested goal because of X, Y, Z, and giving them the option to say, not interested, so we're not forcing people to take suggestions necessarily or forcing them down paths, but we're surfacing information and decisions for them in a way where they can so that they don't have to dig through all of this data through ADT feeds and EHRs and all of that. We're able to like pull that together for them, and then they can apply what they know about the patient, their like human lens, to say, this is the right time for this, it's not the right time for this, or actually this just isn't relevant at all, and I don't want to do this for a patient or with a patient. So I think that's one piece, is like really focusing not too much on forcing, but on suggesting. And I think that's the thing that's coming to mind most for me. I don't know, Sarah, if there's anything else you want to add there.
Yeah, no, I completely agree with that. I like our CEO, Roger, kind of describes how we're trying to use technology to like give our humans superhuman powers. And so how do we, again, surface insights in a thoughtful way, like Hannah described? And then how do we just like try to put out as much admin stuff as possible to allow our teams to focus on our patients. So trying to use various AI tools to support them in just like doing the more engaging, motivating work.
Yeah, and so in terms of engaging and engagement, so you also talk about like you were able to reach, I think, 60% of contacted patients, which for a population that you serve, at least to me, sounds pretty significant. So like, what are some of the challenges that you encountered while trying to connect with these hard to reach individuals? And like, what are some lessons learned of like things that you tried and failed and things that you have success with in terms of like engaging patients into your care model?
Yes, we have tried all of the things. We've thrown lots of spaghetti at the wall, and some things have worked and some things that haven't. I'd say like generally we think about engagement as sort of the step-by-step, like, are we targeting the right patients? Are we outreaching all of the patients we're targeting? Are we reaching the patients we're outreaching? Are we activating the patients we reach? And there's kind of different strategies we're testing to get better at each of those steps. I think like where we've made the most progress and where our work, you know, feels a little differentiated from lots of patient engagement work I've done in the past is our data science team is like constantly analyzing who is most likely to benefit from our services based on results, which is helping prioritize patients for outreach and guide when and how we attempt outreach. That has been super valuable. On like reach rate is, I think reach rate is a big challenge. And I think kind of two places where we have learnings. One, like community-based outreach is very effective, but very challenging to operationalize. So like we have seen our highest reach rates and activation rates when we're meeting with patients who find themselves at a facility for a hospital visit or ED admission or in the community. But initially, you know, we were sending CHWs all over the place to meet patients in a way that made their workflow really challenging. And we kind of honed in on like coverage of the highest volume utilization facilities in our communities and having like consistent CHW coverage at a small number of facilities with a high number of volumes, saw successes from that. Focusing on community-based outreach for like our highest priority patients. So it wasn't so disruptive to a CHW's broader workflow. And then I think like every organization out there, like MCO contact information is really bad for, you know, a Medicaid population in particular. So I've done lots of experimentation around integrating additional data sources from provider partners, from EDT feeds we found are helpful, from other vendors out there claiming to have better contact information, and like continue to test and learn around that. And then maybe lastly, like when we reach a patient, like, do we activate them? Like, how do we get them to build trust with us? Have done lots of testing of outreach by different care team members based on sort of patient profile, which has been interesting. I'd say early on, we assumed that like our care coordinators and CHWs would be doing the vast majority of our outreach. And pretty early on sort of had a nugget that where there were patients with kind of acute pharmacy issues that we could see in our data set, where our pharmacy technicians called them and said, hey, like, it looks like you have a problem. Can I help you solve this problem? Was like a pretty amazing way to build trust and then kind of introduce who we were more broadly. So there've been a few nuggets like that on like, how do we leverage the multidisciplinary team broadly to kind of build trust and establish that initial relationship that can then expand to our care team more broadly.
I love that example because most try to like hard sell and have like call center people just like try to onboard them. But to your point, first try to be helpful and then activation will automatically follow. We only have 4 minutes left, and maybe one thing that I really liked about the paper was the last bit where you emphasize the importance of like patient stories, because that's eventually why we are here today and why we're active in healthcare. So maybe Hannah, can you maybe explain the story like a little bit, but then more importantly, how do you share such stories across the team to keep the momentum and the drive to make this work continue?
Yeah, absolutely. I mean, I think, Rick, like you said, patient stories are what makes this work real for our care team members who are delivering care, for the support teams, and for our partners. And so I think, not to undersell our quantitative data, I love all of our quantitative data, but at the end of the day, our care model is about humans helping other humans. And I think numbers can't always get to that humanity, and being able to, hear that, yes, we help this many patients with this issue and this many patients with this issue and this many patients with another issue, right? But like often those are all coming together in one person who also has all of these other things going on. And I think these stories we found to be really, really critical across our organization for keeping us grounded in what we do, and constantly pushing us to make sure that everything we do is really designed for real life, whole person care for the populations that we're serving. I think this has also been really helpful for our partners. I think they're not unfamiliar with these patients necessarily, but I think sometimes the work that community health workers and often pharmacists, oddly, what they do can feel like a black box. It's like if you're not focused on it, you just don't really understand like what is that value that we're able to deliver. And I think these patient stories really help kind of unpack that and illustrate the value that we can bring to these wraparound services like Sara was mentioning. And so, just really fundamentally, like we've got a tracker where when people have a good patient story, we're like making a note of it so we can come back to it and not forget it. And our care team member meetings are structured to routinely talk about patient stories, on a weekly basis. And then we have bi-weekly all company meetings that always start out with a patient story, and we kind of alternate markets that we're hearing from. Again, I think it's so impactful for our legal team and our compliance team and our finance team, and obviously everyone else who's like actually, building and then delivering this care to hear that and to stay anchored again on why we're here and why we're doing what we do. So I think it's a really powerful tool that consistently, I think, is one of the most meaningful parts of our all company meetings.
Yeah, I agree. That's also what I wanted to emphasize, because it's easy to look at numbers like 60% reach, but if you then talk about this person that you reached and the impact that you had, that's what matters. So I hope that's obviously a big takeaway from today. Time is up and I don't want to take more of your time. The last thing that I wanted to say, I accidentally already said it in the chat, but we are organizing a conference in Nashville next year. So we have a few spots left. So feel free to sign up. I would definitely recommend to do it today or tomorrow, because I think by Friday we will be full, and I hope to see you there. And then Hannah and Sara, thank you so much for sharing some of the wisdom, and yeah, thank you for what you're doing for the community, and hope you have, or you will reach even more patients in 2025.
Well, thanks for having us, Rick. This was fun.
Thank you so much.
Thank you. Have a wonderful day. Bye-bye.